Thank you very much. I am Arthur Webb, the President and CEO of Village Care of New York, and it's a real privilege to be part of this session today. We also want to thank New School and AARP, ASA, NIASA, ACA, CCLC, and in particular, I want to thank Larry Minnix for his outstanding leadership on this and so many other issues. Thank you, Larry. Great job. And I'm going to pick up on someone who said that, Mike Burgess said, it gave me a new metaphor to use, the silver moon. Well, for those who know New York City, you are right in the midst of one of the most fantastic Halloween party opportunities for all of you. At 3 o'clock is the Children's Parade at Washington Square, which the Village is a sponsor. And starting on 6th Avenue is the late night parade, which I used to participate in. 2 years ago, I was a judge. If you really, really want to see New York at its best, or see some people at their best, hang out. You'll have an absolute fabulous time, as Dick knows. So whether or not it's a scary day or a scary night talking about this issue, I guess we're all baying at the silver moon. When you look at the title, New York Aging Well into the Future, I look at my panelists and I'm wondering whether or not it describes our panelists. Aging well or aging well into the future. I said to Lou earlier that he helped bring down the average age of our panelists. Yes, look, we had the framing of the issue this morning, which was really fantastic. And I was struck by one comment that Larry said, and you don't usually hear this when you talk about national issues requiring national solutions. He says it is manageable. Then he further referenced if it had been put in when Claude Pepper wanted it to put in, we would have a very different set of dynamics facing the country. And that's really good. Whether or not you have to go to IHOP to get your coffee, that's a different issue. Look, families take on this task in a quiet isolation with great dignity and courage without a lot of support, which is one of those remarkable things about America, maybe the worldwide. But as all of you know, and I'm sure you get them, I get an enormous number of calls weekly now from my colleagues, my peers, my intelligent ones who said, what do I do? I have no clue. And that's a very frightening experience when you talk about it on the other end, and my colleagues who are quite knowledgeable about things. Look, no families really plan, individuals don't really plan. And let me just tell you my own experience. I took out long-term care insurance years ago, my wife and myself. We have a Cadillac program. You cannot buy a better program in this country than we have, right? I have long-term disability that pays an enormous replacement in my income. I have no debt. I don't know why I feel so vulnerable. I don't know why there is this sense of fear that kind of grips us. Every day I think about what the options are. I went as far as to get my organization to build a $44 million new nursing home on Houston Street with private rooms. That's one solution. The other solution is convince my wife, we have this wonderful brownstone, to turn it into an illegal nursing home and bring in folks. And if you think about it, that's what board and care homes were, that we closed 7,000 of them in the 70s. So you're going to see a lot of options, not necessarily the most palatable ones, the most moral ones, or the most affordable ones, but people will come up with solutions. So today's panel, we've already had the framing of the issue. Today's panel is about solutions. Solutions take time to bring to life, but I'm again convinced what Larry said, that indeed they are manageable. And in New York State, I've been in New York State for 42 years and been through lots of different things. And there's 3 or 4 things that I have learned about being a New York State citizen. One, I trust my leaders, and I trust the intelligence of those. I trust the history of the great state of New York, which has always found ways to solve these social problems. The second thing is the wisdom that brings, and what people on our panel actually have this. These folks have been working very, very hard over many years to try to find things that are actionable and responsive to the folks in front of them. States have been the crucible and place of innovation in this country. Dick is part of a Reforming States group, which is a remarkable group of individuals across the country. Leaders similar in Dick's position have come up with a lot of very important reforms at various state levels, pension reforms, et cetera. So we have individuals that are just great. Lou and I got together at a panel in 1996, years ago, working on solutions, and his group has actually put forward a solution. Carla has been working so many years and is really quite knowledgeable. I know Mark is not here, and we wish him well. Deborah's not here, so she has this enormous task to fill the seat of those two individuals, and quite honestly, as I said earlier, we have someone here who actually knows how this all works, so we have Carla to thank for that. And Audrey is just an incredible colleague and just wonderful. She has led the way on culture change and just a remarkable turnaround in our nursing home world. Beyond that, though, she brings a breadth of understanding, again, and wisdom. So we have a panelist, a group of panelists who will focus on solution. Here's the rules of the day. Each panelist will be given 3 to 4 minutes to speak. To talk a little bit about or address what solutions they perceive or will offer. And then we're going to turn into more of a question and answer approach. All the panelists were sent a set of questions, as I were. And so they have those set of questions, so full disclosure to all of you, these are not necessarily my creations, but they are a set of questions that Larry and Doug Pace and Carl and Dan and others thought would really sharpen the issue about how to think about the solution. So without further presentation or moment here, what we should try to do is start. And out of deference to our elected officials and chairman of the New York State Assembly Health Committee, who took office at 24 years old. There's a continuous debate between he and Tom DiNapoli about who is actually the youngest public official. But Dick has been in the state legislature and provided leadership since the early 70s. I think he's close to the longest serving state assemblyman at this point in time. Close to it. And so with that, I'd like to introduce a good friend and colleague. And you can stay seated if you want to, Dick. It's up to you. Oh, come on.
Well, thank you. Art Webb is clearly one of the really forefront leaders in Albany and in New York State, and we need more people like him, because he just said, I wrote it down, I trust my leaders, I trust their intelligence. So I hesitate to disagree with him. I was 23 when I was elected. Not the youngest ever. The youngest, there have been a couple of members of the legislature elected at the age of 21. One of the youngest was Teddy Roosevelt, who was 22 when he was elected in 1880, I think. Yes, Tom DiNapoli was elected when he was 17, but that was to a local school board, so, you know, does that count? I also need to say that since Kemp Hannon couldn't be here today, as I occasionally say, you can just, you know, he agrees with everything I'm going to say, so, you know. Anyhow. Yeah, actually for several years I've been the longest serving current member of the Assembly. Assuming I am reelected on Tuesday, in January, I will be the longest serving member of the Assembly in the state's history. Not the longest serving state legislator in New York, as far as we know. That was John Markey, who was in the state Senate for 50 years, but at least once he retired, I knew where the goalpost was. I'm not sure that I will, well, I'm not going to try to answer the questions that are on the list one by one, but I hope my answers will be embedded somewhere in what I'm going to say. So let me try to plow ahead. You know, we're all going back to Albany on November 18th, well, all of the legislature going back to Albany on November 18th to deal with the state deficit. We've all heard the governor and some of the legislative leaders say very emphatically, everything is on the table. But then they say, well, except taxes. Now, I'm reasonably confident that when you heard them say everything was on the table, almost everyone in the room said, now, wait a minute, my piece, you know? Not too much on the table, I hope. How many of you, when you heard people in Albany saying everything's on the table except taxes, how many of you put out a statement or said to almost anybody, the part about except taxes is an outrage? My guess is that not too many of you said that. You all thought immediately, don't cut my part of the budget. How many of you said taxes really have to be on the table? Now, and you know, during the last any number of years, when every year practically, certainly when George Pataki was governor, there were proposals to cut taxes, particularly taxes on higher income brackets. How many of you, when you heard that, thought, oops, that's not so good for me? My guess is probably not. Now, you know, when people start talking about capping property taxes, it takes the teachers' union about a half a second to say, wait a minute, that screws education. They understand the very direct link between taxes and education. Now, that's partly because in most communities, there is a separate property tax bill that says school tax on it, so it's kind of hard to miss. But surely we're all in this room smart enough to know that every dollar we pay in taxes to the state of New York, a third of that dollar has Medicaid written on it, maybe not on the tax bill, but surely we all know that's where our tax dollars go. And so if roughly half of property taxes going to education sinks in with people who advocate about education, why doesn't a third of general state taxes going to health care register with health care providers, advocates, whatever we all are, when people say taxes are not on the table, only cutting spending? Speaking of education, you know, do you ever hear anyone saying the following? Oh my God, those middle-class people, they're taking a free ride. They send their kids to public schools like it was an entitlement. Do you ever hear people say, angry politicians saying that? Do you ever hear angry politicians complaining that people just get married, they get pregnant? Do they put money aside to send their kids to kindergarten? Do you know, I mean, how many people do that, put money aside to send their kids to kindergarten? Yes, some people do. But the vast, particularly in my district, I guess, in Manhattan. But the vast majority of Americans do not, when they're thinking about having children, say to themselves, how are we going to pay for kindergarten? Because they figure that's, you know, they're going to be able to take a free ride on the school system. Now, when it gets to higher education, oh, and just again on elementary, secondary education, have you ever heard anybody say, you know, people just send their kids to school, they don't worry about which one is more cost effective? Do you ever hear angry politicians saying, you know, they have things like sports and music in my local school. You don't need that in order to, you know, be Joe the plumber. Why are we paying for that? I don't think so. Any school system you know where people run for office saying we're going to get rid of the athletic program? I don't think so. Do you ever hear people saying, you know, people don't appreciate the value of our schools because they have no skin in the game? You know, they don't, if people had to pay out of pocket for, you know, to get their kids to learn how to read, boy, they'd care more about it. I don't think I've ever heard anyone say that. Now, with higher education, it is a little different. Even with our public colleges, we do expect people to pay deductibles and co-pays. We call it tuition, but we do expect people to do that. Although in New York State there was a time when suggesting that there be a deductible to send your kid to City College would have been an outrageous thing to say. I'm old enough to remember that. I actually, when I was in high school, went to rallies protesting Nelson Rockefeller's proposals to impose tuition at the city colleges and at the state university. You know, for some reason, we don't think of health care in that way. Now, I think I know why we don't. My sense of it is that in the early 1800s, this country made a revolutionary, country-changing decision that universal, mandatory, free public education should be the rule. In the early 1800s, we did that. It didn't occur to anybody in those days to throw health care into the mix because, you know, in those days, what was health care? You know, leeches, people with really nasty saws cutting off your legs. You know, there were, you know, if you were sick, maybe, you know, a nurse would come and help make you feel comfortable until you died. I have to be careful when I say that because I said that once to a group of nurses, and they were very adamant that even in the 1800s, that wasn't all nurses did. Okay. But it certainly never occurred to anybody in the 1800s that that was something that the government needed to pay for. And then came the Gilded Age in America, and we stopped thinking about adding things to the list of services that government should provide. Fortunately, in the depths of the Civil War, Congress enacted the Land Grant Act, so even then we understood that higher education should be a government responsibility. But, you know, what have we added since then to, now you might say, well, Social Security and Medicare, but I would say in the early 1800s we understood that really poor old people and really poor people should be taken care of in some way. We didn't care for them very nicely, but we cared for them. So I would argue that even Social Security and Medicare and even Medicaid have roots in the 1800s, but somehow in this country the notion that, that health care is a right and not a privilege didn't take hold. I think those of us who care about health care ought to be working at every opportunity to change that paradigm. You know, one of the questions on this list, number 5, is why is New York's long-term care system more dependent on Medicaid coverage than that of other states? A good, interesting question, but the second part of that question is what troubles me. It says, how could we change that? Now, to me, that's a really easy question. I just don't understand why one would ask it. But it's an easy question. Just pull out the 12 Pataki budget proposals, look at the things that the legislature rejected, and there are your answers. It's easy as pie to cut down on what New York State spends on Medicaid for long-term care. My question is, why would you, at a forum like this, ask people to come up with suggestions for how to do that? You know, there's discussion about, you know, following an insurance model. As if in the health area, the insurance model has been such a smashing success. Are there thoughtful observers of our healthcare system who do not understand that the fact that in the midst of World War II, when employers couldn't give people raises, they said, some of them said, oh, we could give them health coverage instead. And ever since then, we've been going down that path. Are there thoughtful observers of the healthcare system who don't look back on that phenomenon and say, oy, if we could only relive that? You know, when communism fell around the world, you know, delegations came to America, and some of them, for some reason, came and talked to me, you know, about, you know, to learn about various things. I have never had a delegation that came to me, whether they were from Indonesia or Sweden, or every so often I get Chinese delegations coming to talk to me. A few months ago, people from Italy came to talk to me. I have never had anyone from a foreign country come to me and say, you know, Mr. Gottfried, we hear you've got this health insurance system in America. We'd like to model what we do in X country on what you do in America. Can you tell us how to do that? No one has ever come and asked for that kind of advice. why would we want to do that? Now, again, I think I know why. It's because we all know that in this country, when you say taxes, people, you know, break out in hives. And so if we can call it a premium instead of a tax, you know, maybe we can get away with it. But, you know, part of me wants to say, this is New York. Things are a little different here. You know, in New York, the leadership of at least one house of the legislature can stand up and say, we demand that we raise taxes on wealthy people. And you know what? I'll bet there are going to be more Democrats in the New York State Assembly after Election Day than there were before, even though, heaven help us, I don't know how we feed 108 mouths in the Assembly Democratic majority. But it certainly has not cost us seats in the Assembly being perceived by the public as the party that wants to raise taxes on wealthy people. You know, I have one of the wealthiest districts in the state. I advocate raising taxes on wealthy people. Not a single constituent of mine has called or written to complain about the millionaire tax, even though I've probably got more millionaires in my district than almost any district in the state. You know, the $2.87 a day proposal, you know, if it averages out to that, to me that's fine. Because the share of that, if it averages out, the share of that you know, a CEO will pay, you know, will be a lot more than $2.87 a day, but, you know, he or she can easily handle it. But if it's $2.87 a day across the board, which is the way insurance premiums work, you know, the insurance company doesn't care whether you're the CEO or the janitor. They want their premium. You know, $1,000 a year is, you know, for some people in my district, they work for a month to earn that. There are a lot of people in my district who, on the first workday of January, earn that $1,000 well before lunch. $21 a week, which is, you know, $3 a day, $21 a week for many of my constituents, that's more than doubling their subway fare. And if I proposed to my constituents that we raise the subway fare from, say, $20 a week, put an extra $21 a week on the subway fare, I think even I, in my district, would be in trouble. You know, we talk about responsibility. I think responsibility is speaking up for health care being a right. And in this country, when you say something is a right, that means we turn to the government to assure that you get it. You know, if you have a right to send your kids to school, that doesn't mean in the sense that you have a right to send your kid to Harvard. You know, if you can get in and if you can pay, yeah, you know, the government won't stop you from sending your kid to Harvard. That's not what we say when we say people ought to have a right to send their kid to college. We mean that if your kid is ready for college, government has an obligation to see to it that there is a seat in a college for your kid. And if you have a right to send your kid to kindergarten, that doesn't mean that if you can afford it, we won't stand in your way. That means you simply have to say, here's my kid, he's 5 years old, where's his seat in the kindergarten? And I think we all, yeah, I'm just about done. I'm using some of Kemp Hannon's time. I think we all have an obligation not to try to figure out how can we reduce the role of publicly accountable and publicly funded health coverage in helping to provide long-term care. I think we all have an obligation to say that of all the parts of the healthcare system, the parts that work best are the parts that are accountable to the public and the parts that are more fairly funded. You know, is there any part of the healthcare system that Americans are more fond of than Medicare? I don't think so. And yet, you know, Medicare is, you know, if John McCain, you know, were really true to his principles, he'd be going around saying Medicare is socialism. And it got enacted because of the efforts of a lot of community organizers. Why? I mean, it seems to me if we are concerned about long-term care in the future and making sure that it is available to all of us, I think the way to do that is to make sure that everyone in society contributes according to their ability to pay, and that for some members of society that means we're not going to ask them to pay at all, and for some members of society we're going to ask them to pay actually a lot more than $2.87 a day. And we're not going to try to, you know, cajole you into making that payment. We're going to require it, but in return, health care, including long-term care, will be a right, not a privilege. Thank you.
Stand up. That's great. Be careful.
Good morning. When Doug asked me to talk this morning, he asked me to focus on two things. One is the workforce, and the second is the implications of cultural transformation or culture change on the workforce. So beginning with the question, who's going to care for my mother, or for many of us who, as Art reminded us, are getting older, who is going to care for us, is what I'm actually going to focus on this morning. We all know that long-term care is an intimate, personal, relationship-centered event and series of events, and that the workforce and the development of the workforce is critical to all of that. This concern was reinforced recently by a Commonwealth study that interviewed more than 1,100 thought leaders in America, and long-term care workforce was ranked the #1 concern by 85% of the people, followed by financing at 66%, followed by achieving quality at 60%. But we also know that long-term care workers have typically characterized their work as being organized in a hierarchical way, marred by a culture that doesn't provide adequate supervision, doesn't respect the knowledge and the skills that nurses and aides bring to the work, and doesn't encourage information sharing among employees at different levels. We know that in order to make changes, we need to transform long-term care into places where people want to work. And those are the kinds of efforts that we're seeing take place in New York City and around the country. We know that these solutions need to respond to the fact that workforce issues are cyclical. Because there's a well-documented shortage of competent staff, there is this inevitable cycle of high turnover, which leads to more vacancies because no one wants to work in a place where there's not good staff, which leads to difficulty attracting new employees. We know that all of this is impacted by how people perceive long-term care today. Why would I want to work at a nursing home? It is too depressing. We know that wages and benefits, while not an issue in New York City, are an issue around the country. We know that these environments are not conducive to being places where people want to work. And we know that often there's not enough money for education and training. So what happens? People can't get services. Resident safety is compromised. Quality of life and quality of care are compromised. There are increased costs. We can't recruit and train staff, and as a result, we use agency and temporary staff. There are increased costs. There are difficult workloads. As a result, we can't do training, we can't supervise, which causes people to make mistakes, have increased workers' comp, increased disability, and it's only going to get worse. ASA recently convened a talent cabinet to look at these issues and come up with solutions. And the 5 points that we're addressing right now are: first, define what the core competencies are. An aging worker, meaning a person who works with older adults, not me who is aging, is not the same in a hospital, it's not the same in an ambulatory care clinic, it's not the same as long-term care. We are people who rely on interdisciplinary teams, nurses that delegate care tasks to CNAs. We have to complete MDSs that no one else in aging has to. Once you define what the core competencies are, where are they going to be taught? Who is going to agree on them? How are we going to impact this on a national level? How will that relate to job descriptions? How will that relate to performance? We also need to deal with recruitment and retention. We need to be able to say to all of us in this room, if we only had $10,000, how would we spend it and where would that impact be? In New York City, we've had some successes because of the partnership with 1199, CCLC, and indeed the Department of Health, which initially provided recruitment and retention money and quality improvement money, so that labor and management and staff could together figure out how to change the relationships, how to end the hierarchy, how to jointly determine what the problems were and what the solutions were. Empowering and engaging staff in this way has had a positive impact at Jewish Home on sick call, staff satisfaction, clinical outcomes like pressure ulcers, and resident autonomy. And my colleagues in this room have had the same impacts and results. Changing the culture, whether we call it culture change, culture transformation, person-centered care, is all fundamentally about how to change where the power is and how to change who's at the center, which is the older adult. Another Commonwealth study looked at the fact that the more culture change principles are embraced, residents determine their own schedules, decentralized decision-making, the more we can expect increased staff retention, increased occupancy, decreased cost. One example is that culture change adopters are more likely to consistently assign the same nursing assistant to the same resident. It is about relationships. So now take it one step further. If one could imagine the same worker, whether a home health aide or a CNA, makes the same money, has the same benefits, has the same training, follows the elder from setting to setting, we can imagine a place where elders get the care they deserve. Any new financing plan that is going to be successful has to remember that the client is at the core. But until we empower, respect, and pay people enough, until we value the workers, until there's adequate funding designated for quality improvement, recruitment and retention, and indeed the core of what we do, we won't be at a solution to the question, who will care for mom? Thank you.
Lou, you want to go next?
Is this on? Yes. I know I have 3 or 4 minutes, but could I borrow Senator Gottfried's watch to time that? As Art said, we met 12 years ago on the governor's task force on long-term care reform, which was convened in anticipation of the problems that we're facing here today. And the task force issued a report called Securing New York's Future. I don't think we did that job. We issued a report that was in large part ignored by the legislature because in times of economic prosperity with good budgets, these types of issues tend to be pushed to the side and we focus on other things. We were not foresighted enough to take heed the call of the task force to reform the long-term care system. And so what's different now 12 years later? Are we in better shape or worse? Well, we have a Medicare system that is fundamentally failing. It has retrenched from any type of long-term care services, whether it be skilled nursing home care, 100 days, which people think they're entitled to, or the 35 hours a week that you used to get for home health care under Medicare. Those days are gone. We now have people being pushed onto a program that was not designed for long-term care, but has become the payor of last resort for long-term care, and that's Medicaid. And as an elder law attorney, I deal with Medicaid day in and day out. And I've litigated Medicaid cases in the New York State Court of Appeals, and I sit with my clients on a daily basis and try to explain to them the Medicaid program. It is not an easy task. It's an impossible task because most of us don't understand the Medicaid program. And we have a huge push to bring people back into the community, to bring them into that independent setting and to provide caregivers and to pay those caregivers adequate wages. But how are we going to do that when the reimbursement system is Medicaid and you have the consumer-directed program, the personal care aid program, the Lombardi program, the transition and diversion waiver program, the TBI waiver program? Most social service agents who sit at the desk in the agencies administering Medicaid don't know the programs that are available in New York State. How are consumers supposed to make sense of that? It doesn't work. The system is broken beyond repair in terms of trying to finance community-based care or any other type of care through the Medicaid portal. So we've become overburdened, and the demographics and the failure of Medicare and people's longevity has put our clients at risk. And my constituents are the elderly, people with disabilities, and their caregivers and families. And that's who we represent on a day-to-day basis, trying to navigate the maze of care. Several years ago, there was a law passed. I guess we did our job a little too well, because there was a law passed in Congress called Granny's Lawyer Goes to Jail. Anybody remember that? They actually slipped a piece of legislation through in the Kennedy-Kassebaum bill that made it a federal crime for me to talk to my clients about Medicaid. And we as a bar association sued the federal government and got an injunction against the enforcement of that law, which actually still sits on the books in Washington. So I'm a felon at times, and that's just the way it is. So we convened a task force, the Bar Association Elder Law Section in New York convened a task force, and we issued a report back in 2005. And part of that report was authored by someone who many of you may know, Gail Holobinka, who developed the New York State Partnership for Long-Term Care and ran the partnership for 10 years. The partnership is a success story. It has worked. There have been 83,000 partnership policies sold in New York State to date. There are 62,000 policies in effect today in New York State. How many people are on Medicaid having exhausted their partnership insurance benefit? 77 in the entire state of New York. The partnership has worked. It was based upon logic, sound fundamentals, good research and actuarial studies. And so the problems with the partnership, which were identified in the compact report, were identified in our task force report, are addressed in our most recent proposal, which was introduced in the Senate back in March of '05 and passed by the Senate unanimously, and that is the Compact for Long-Term Care. There was a handout on the table. I hope you grabbed it. It explains the compact. It has the flow charts and the concepts. But here's what the compact is designed to do: to preserve Medicaid for the people who truly need it, and to remove the perverse incentives for people to divest themselves of their life savings in order to access health care. That is not the way the health care system should be designed. Also, to provide consumers access, choice, and quality long-term care services in the setting most appropriate for them, and to allow them to utilize their own resources initially in order to pay for that care, whether it be their own bank account, the reverse mortgage in their home, or long-term care insurance, which right now cannot be sold in a quantity that makes a difference because of the cost. You have the two issues. You have groups of people, the people who are uninsurable and the people who simply can't afford the premiums for long-term care insurance. The problem, one of the problems that's fundamental, is that you have an undefined risk. If I need 10 years of care and I have dementia and I'm in a nursing home and a nursing home costs $150,000 a year, I need $1.5 million of long-term care coverage to pay for my care. So what the compact does is tries to rationalize that by allowing people to pay a defined risk. And this is one of the things that came out of the governor's task force report 12 years ago, a defined risk based upon your means, and to borrow from the partnership, which is working, the same types of actuarials to say 3 years of care is a right number, because 95% of the people attrit out of the system within that 3 years before they ever hit a dollar of federal or state money. And so the compact tries to pull people in to allow them to spend their own money wisely, to formulate their own plan of care with their own care provider, to be able to pay the expenses through that plan of care with their own money or with insurance dollars that they can now purchase in an amount that is defined in advance with lower premiums, and then to have the government provide the backstop, the subsidy for long-term care once those resources are exhausted and their pledge is met. Those are the fundamentals of the compact. We think it has a rational basis that has been proven to work through the partnership and really is the natural extension of the partnership, at least in New York State. And New York, this needs to be a federal solution. New York was a leader in the partnership. And in 1993, when that was enacted in New York, the federal government put a stop to any other states. There were 4 states that were allowed to do the partnership. Well, guess what? The federal government now came back with the Deficit Reduction Act of 2005 and opened up the door to all states now to do partnership insurance. So fundamentally, the concepts work. We believe the compact embodies that same logic and same rational thought, and we're right now discussing that with the Department of Health. We've gone through 3 governors as well, beginning this with Governor Pataki, then to Governor Spitzer, and now to Governor Patterson. So, but we have great people with Joe Baker and Mark Kissinger leading the charge for the state, looking at all of the different alternatives, and we hope this gets to be one.
Great, thanks. Carla?
I'm also going to stay at my seat. I'm pinch hitting today for Mark Kissinger and for Deb Backrack from the Department of Health. Many of you I know from various, yes, that's what I'm going to do next. Thanks. Various experiences in long-term care, but my name is Carla Williams, and I'm the Deputy Director of the Office of Long-Term Care. First, I'd like to say there's, as we all know, there's no silver bullet. We talked about silver moons and silver other things, but there's no silver bullet in terms of what is the answer? What are the solutions? It strikes me as we sit here and have heard various panelists and listened to, Joe and Mike, who really did a great job at kind of laying the groundwork, is that there's so many moving parts that have to be addressed to have real solutions. And what is the solution today is not, I don't think it's the solution that we need for the future, frankly. So there needs to be both short and long-term approaches to this problem. And I was sitting here, I thought we were going to do a panel and get questions. I was told, oh, you get, 1 or 2 minutes to say a few words. So I kind of sat here for a few minutes and decided that what I was going to do is review a few states. First of all, when we talk about why we don't plan for long-term care, it's because we're in a state of denial. It doesn't become a problem until you're confronted with it. My personal story is trying to convince my mother, who said, I'm staying in my home. I mean, she said that when she was my age. She was fortunate to have 7 children. But when we started to try to say, okay, Mom, you're going to redo the house, let's put the bathroom in downstairs, that didn't happen when she added the sunroom. The bathroom finally got put in within 12 months of her death. So often we just live in a state of denial, and it is very difficult to have people think about, even though they make a decision about what they think they want, it's just a state of denial. We're in a state of distress. Joe talked about the fiscal situation and the tough decisions that are ahead of us, which leads to a state of disturbance. We continue to head towards reform. There was forward thinking by the Spitzer administration. It's been supported by Governor Patterson. The office, just the creation of the Office of Long-Term Care, I think, is significant in the recognition that this is an issue that's important and needs to be focused on. I think the disturbance comes, of course, from the fiscal crisis, but I think Joe referred to it, that this really is an opportunity for solutions and creativity, even in an environment where we know the pain is going to happen. We can't really change that. And then I would say we're in there's part of it that's a state of fear. There's a question about, what do you fear most? Well, we know that, as Churchill told us, it's fear itself. So, you know, if we act like we've gotten caught in the headlights, for those of you that are from the North Country, you know what that means. And even, you know, I know Westchester, there's lots of deer. So, you know, the Taconic, you can also see them. I think it's really not an option to get caught in the headlights, and that we are going to move forward. And I would like to say that, you know, it's clear to me that if you observe Governor Patterson, one, he's an amazing guy in that he's very confident about being very direct and honest about the problem, you know. He speaks very clearly about the issues we confront. And frankly, he's quite knowledgeable about the challenges of disability. So I think those things are really actually quite good for the issue of long-term care and being able to be creative about the solutions that we're going to have to come up with. I think the short term is going to be really painful, though, and that we can't lose sight of what is, you know, what we have to do for the future in this short term. So, thank you.
Thank you, Carla. Many of the panelists have already addressed some of the issues, but I want to start back where you ended, Carla, and start with yourself. And one of the questions I thought was really very pointed is what you ended with. It was, what are the fears and what are your hopes, not only short-term, long-term. Obviously, you've already stressed the idea of our fiscal crisis. But what are some of the hope side of all of this? You tend to be an optimistic individual, so what's the hope side of this?
The hope side is that, as I've said, that, you know, in an environment often where there is struggle, that's when creativity can occur. And I think also Joe also kind of framed this in the idea that now's the time, you know, to not walk away from putting your toe in the water and creating investments, even if they need to be small, to start a momentum in a direction. I also hope, as President Kerrey had talked about, that the federal government really does get engaged because, frankly, we can't do this alone. States cannot do this alone. So I think I have a great deal of hope that the change in Washington will support states in terms of this issue, but even the broader issue of, and my question about the proposal, the long-term care solution proposal, is why aren't we using Medicare as a vehicle for that? So I think we should engage in that kind of discussion. It is already in place. We can do it. There's been political momentum to modify Medicare in the past. So I think that those are all some of the hopes that I have, that, you know, we don't just get mired in that this is a state problem and it's not, and it is bigger. It's right. Bigger.
I think that's very helpful. Why don't we just continue back down the panel on that hope and fear issue. Lou, starting with yourself, I don't think you mentioned that your proposed legislation has had a good hearing and it passed, I think, the state Senate. Is that right?
No, actually, Assemblyman Gottfried's committee and the other committees in the Assembly, Aging and Insurance, had a hearing in December of 2006 right here in New York City. And I think there were 34 or 35 people that gave testimony on the compact. There are transcripts available on that. Most of the testimony was favorable, and actually Mark was one of the people who testified on behalf of the Home Care Association, where he was at the time. So we have all of that out there. The problem is that it has not been a political priority. And there are a variety of reasons for that. And right now we see health care coming into focus, and Medicare would be great to solve this problem, except Medicare is destined to be bankrupt, I believe, in 2019, according to the most recent reports by the trustees. And there's a very compelling letter written by one of those trustees that was leaving, and he said, all I've been asked to do for the last 4 years is sign the report. I've never been asked to comment on it. I've never been asked to consider the funding for Medicare. And this was someone leaving the administration at the same time. This was very recently in the New York Times, back in the spring. And for me, my greatest fear is that we're going to lose the basics of Medicare and the safety net that Medicare provides our seniors, let alone pick up long-term care inside the Medicare program. So I think we really need to look critically at that. But there are some bright lights out there, and there are some companies that have begun to provide services on the private basis, and I think this has to be a partnership public-private partnership. The dialogue has begun for that, and that, to me, is one of the most encouraging things. Also, this report, if you haven't read it, read it. The National Commission on Quality of Care, Senator Kerrey's report, they get it. They got it. They put it down, and for the first time on a national basis, they have framed the issues for all of us to consider. And if you read Chapter 4, it's the financing issue, which we're here to talk about today. They're on point with all of their questions. So I think the dialogue that has been established, to me, brings most hope, and I think we're going to have a sea change in Washington that will allow CMS and the other agencies, which have been a very closed door up until now, allow some dialogue with them as well on how to expand and improve the services that we have. And there's one company that started in Cambridge, Massachusetts, that some of you might be familiar with, called Senior Whole Health. And I love to use them as an example of how private innovation can come to bear here. They're doing dually eligibles, Medicare and Medicaid seniors. They're managing their health care on a capitated basis, and they have been achieving phenomenal outcomes for those people who are living independently in the community and providing them with all their chronic disease management, electronic medical data, and nurse case management for every one of their members on a very small budget. So innovation can be brought to bear, and those technologies can come in. They were the fastest growing private equity company in America last year, according to Inc. magazine, providing care to Medicaid seniors. It's phenomenal, and we can do that, but it has to come through all of the different avenues that we have available to us.
Great, thanks. Thanks, Lou. Audrey, do you want to talk a little bit about what your hopes and fears are about this particular issue?
I think in terms of fear, my fear is that absent federal support in the next year, that the cuts will be so draconian that we end up putting frail individuals and individuals who are disabled at incredible risk. And I suspect that that's everybody's fear, among everybody's fears in this room. On the hope side, from the workforce perspective, I hope that we're able to get the workforce for older adults on the federal agenda so that indeed we can begin to tackle this. And that culture change and transformation of nursing homes becomes the norm, not the innovation.
That's great. Dick?
Well, I think the increased interest in all across society in long-term care, largely a demographic-driven interest, is hopeful. As more people have personal experience with all of these issues earlier in life, there will be, I think, more of a demand for solutions, and that's a good thing. I am hopeful that with, once again, after the early 90s, with healthcare more on the national governmental agenda, that there will be more attention paid not only to preventive and acute care, but that also people will begin to say, what is the government's responsibility in long-term care? And yes, however we organize and finance long-term care, somebody is going to have to pay for it. But I am hopeful that people will focus on what's the most justifiable and effective and fair way to apportion that cost. And I say effective in part because if it is left up to where some people step up to the plate and contribute and some people don't bother, that's not going to be a very effective way to pay for the care.
You know, it's interesting. All of us have been working one way or another to try to reshape the delivery system. So let's ask about what the constellation of factors are to put this on the public agenda, and try to answer the question, will baby boomers really be a force for change on this issue? I don't know. Carla, do you want to start?
Simple answer is yes. The baby boomers, many of us in the room are baby boomers, have had an impact on every social issue that we've confronted as, you know, we've aged, you know, whether it was voting, just the variety of issues. So will we impact this issue? Absolutely.
But, you know, age is not necessarily a good predictor of becoming a socialist. In fact, I think the studies are extremely clear and more pronounced in this latest election that as you age, your voting patterns tend to be the same as they were when you were at 20 or 30 or 40. It's the most interesting set of dynamics. So let's continue on this question about baby boomers actually influencing the shape of the public policy priorities. Carla, you want to say one more?
Well, I just wanted to add one more thing about the simple answer being yes, but I think the other thing that we have is that there's another dynamic that's not been measured well and is difficult to predict, and that is where baby boomers tend to be a healthier group of people. A lot of, I can't, you know, I have to mention smoking. You know, Dick's on the panel. He was, you know, just so involved in changing that behavior, and it has changed. So that is going to affect how we are as individuals. I think hopefully we're going to have a healthier group of people.
Good.
And
well, that gets to one of the other questions about taking care of your own health as a start point. That's a no-cost kind of contribution.
Right. These are smart things to do.
Yeah.
Right.
Lou, your business practice as well as your public policy work tends to focus on some of these aging baby boomers. Do you see them really as a force for change here?
Being one of them, yes. And I have a personal stake in this, too. My mom is now deceased. She had Alzheimer's. So I was the caregiver child, along with my sister. So we lived through the saga of an Alzheimer's parent. And I have 3 children. They're in their teens. I'm looking at them going to college and hoping I can pay for that. So I'm looking at this from a lot of different directions. And I know what it did to our family, having to provide that care to my mom, and all of the gut-wrenching decisions that we had to make that we received very little guidance for. And I'm in the business, and I have contacts in the business, and I could not get answers or care because they didn't have the caregivers in a rural area where my mother lived. So we couldn't staff her case 24/7, which is what she needed. And so that, and then you try to go through and look at the financing, and she had spent her savings down, and we had mortgaged the house to the hilt, so she ran out of money. And she ended up in an assisted living facility next door to me, and that's the only way that we could really do the care, but it was $5,500 a month. And that's a family burden. That's not a Medicaid burden because Medicaid doesn't cover the assisted living. So that's part of the problem. And as much as my professional work has put me into this pro bono seat of trying to help in the public policy arena, it was that personal experience. And I think the baby boomers, legislators as well, and I talked to some of the people, your colleagues in the legislature who are baby boomer children, who are trying to work in Washington, work in Albany, and manage the care of their aging parents. There was a New York Times article last year about how many of the legislators fly from Washington to their home state to be the caregiver over the weekend for their aging parent. So I think it will make a difference, and I think that the boomers will, as they have, as you said, in almost every case, change the system. And I don't want my children 20 or 30 or 40 years from now to be in my seat saying, how the heck are we going to take care of mom and dad? I don't want that to happen. So I do think it's going to happen.
Good. Audrey, do you want to?
I agree, and having also been a caregiver like so many people in this room for all the personal reasons, I think the only thing I would add to what you both said is that many caregivers have had experience with hospice and end-of-life care, and I think that the baby boomers are also going to have a significant impact on that.
Okay. Dick, do you want to have one last comment on the baby boomers?
Baby boomers. I guess I'm on sort of the earlier edge of the baby boomer boom. Hopefully, not only are baby boomers learning more about all of this circumstance and paying attention to what they're learning and voting in response to what they learn. Hopefully, their children are noticing and learning from that as well, because otherwise, you know, I don't think that will be enough. to make a substantial change. But if we've got the much older generation and their baby boomer children and their 20, 30 something grandchildren beginning to pay attention, then I think we've got some pretty good prospects.
Thank you. Self-interest always is a great motivator. And so what we have, again, my trust is well placed with our panelists, and I do strongly believe in the trust of our leaders at all levels, as well as their intelligence. And also the centerpiece of a great state of New York has always been on the right side of taking care of people. So thanks again, Larry. Thanks again, Doug, all the co-sponsors for pulling this session. Thank you.
This is our 5th of these forums, and the compassion that's coming out of Minnesota and New York is very, very clear. So how do we build on that? Secondly, I'm hearing that there's an interest here in saying let's go ahead and say that health care, including long-term care, is a right. It's not a commodity, an option. And this is where people like you have to provide some leadership. I'm hearing there's no objection to pooling the money. We don't care if you call it Medicare Part Z. We found out that red state people like to pay premiums and blue state people don't mind paying taxes. The issue is you have to pool money. And you have to understand that long-term care is different from acute care. What you don't want is people services that help people stay at home. You don't want to say that's another acute care program that gets extremely expensive when it doesn't have to be. So I'm hearing a lot of common interest and common ground, but we're so accustomed to talking about these issues in all kinds of various segments, and we have to get beyond some of our own language to get to a common ground. Now, the only person I know in the world that has the capability to get us to common ground in any kind of administration that comes along is my good friend and thought leader, Eli Feldman. And we've asked Eli if he would come and provide some closing reflections on this event. And then what we hope is with you to begin to say, how do we come up with a major common solution? Because this problem is solvable for a cost of a cup of coffee. It is. So Eli Feldman, come close us out. Thank you very much.
Thank you, Larry. Larry was talking to me before. He wanted to know why I was wearing sneakers. He thought because I was Jewish, maybe it was one of the Jewish holidays or something that occurred. No, I broke my toe on vacation, and that's the only way I can have something on the covering on my feet. And Dick Gottfried, I want to tell you an experience that I had back in 1987. We were one of 4 social HMOs that tried to combine Medicare Part A and B with a innovative coordinated care program called Part C, which we still have around in terms of elder plan. It's still here in the New York metropolitan area. But back in 1987, we had a visit from a bunch of healthcare executives from Japan. And they came to talk to us with an interpreter about elder plan and what we had in mind in terms of reforming the long-term care system. And at the very end, they were very excited, and I ran up quickly to the interpreter to suggest to the interpreter that this was an innovative program, but it was still in the development stage. You know, we hadn't refined it yet. And the interpreter told that to the group, and the person from the group responded back to the interpreter, who then told me that they said not to worry. They imported the Edsel into Japan, and they turned it around, and they brought back the Toyota. So I never worry about those kinds of issues. Also, in coming to today's discussion, I'm reminded a little bit of a Peanuts cartoon in which Charlie Brown is approached by his little sister who's 5 years old and says, Charlie Brown, I'd like some enlightenment. And Charlie Brown looks at her absolutely amazed. He says, I'm shocked. You're 5 years old. He says, are you looking for philosophical enlightenment? Are you looking for things that deal with literature? Are you looking for long-term care financing solutions? And Charlie Brown and his sister turns to him and she says, no, Charlie Brown, my light bulb burned out in my room and I'm looking for enlightenment. So today we've seen a group of people turn the light bulb on and have some very, very exciting discussions. And I just want to ask, does anybody have any questions that maybe got stored up that they didn't ask, that they wanted to ask, and we can direct that to the right person? Yes.
The service sector in long-term care is one of the fastest growing sectors in America. And I like Bob Kerrey's idea of some kind of immediate investment program where we encourage and reinforce people to get into this world. Secondly, the long-term care financing solution supports people already doing the care, and that is informal caregivers that are not necessarily doing this work to make a living, but could be doing it part-time or get support or not have to take off from work. Some kind of national insurance model where the dollars follow the person could very easily reinforce the network already there, but we need some kind of investment in the service givers because of the rapid, and we have to pay them a decent wage and benefits. We have to respect them. And to say that Medicaid has to be cut in our world, the existing world today, Bill Smith said it, that cuts people. And that's counterintuitive to the absolutely phenomenal growing need that every family will face.
Just a comment on that. You know, one of the things, at least in the near future, with the economy where it is, one could probably expect that a number of professionals, nurses and others, who probably were targeting retirement are not going to retire. I mean, if a lot of people look at their pensions today, I was talking to people before, my 403B is beginning to look like a 3B instead of a 403B. So I think in the near term, what you may find is that there is, but you're correct, I mean, it's a challenge. I mean, the current administration was discussing a proposal where basically the most sickest and highly chronically ill individuals would be part of an ice flow theory. Basically, they would bring ice flows to various parts of the United States, and they would then have parties with these individuals being placed on the ice flows with a year's supply of food and medical supplies, and then they would be sent off. And the good part is that it would stimulate the economy because we would have these big parties, and then we wouldn't have to care for these individuals anymore after they floated away. But that was another solution that was put out by somebody. Yes.
It is a fundamental core question, and it comes down to the money, and that's the financing issue. You have to pay a real wage to attract the labor force to bring them in, and putting home health care through the Medicaid portal is choking the home health care market. You do not have real wages paid under Medicare. The agencies can't survive under that Medicaid budget for home health care. And in the compact, the way that that's being addressed is, number one, the first dollars into the system under the compact are private dollars. So you'd be paying for home health care initially at a private pay rate. The compact does not mandate that people, as Medicaid does, spend down every penny to a $13,000 resource level and $725 a month of income. How do you live on that? That's just not a realistic program. To get Medicaid home care services, that's what you have to meet, that level. So the compact allows people to keep more of their income and resources and to pay a subsidy on top of what the government pays, a 10% surcharge for the home health care services. So the provider would get not only the Medicaid reimbursement rate, but an additional 10% paid by the consumer that would increase the reimbursement to a level that at least made it plausible to pay a real wage to those home health care workers. Unless the financing system and the stream incorporates the concept of real wages for the labor force, that's going to be the issue that's going to always plague us. So it has to be private dollars. Medicaid can't sustain it. And the other thing, and we've done probably a dozen hearings up in the Hill in Albany, they always ask the question, well, isn't this opening up the door to more public financing? What many of them didn't even realize was that in terms of Medicaid and home care, there are no transfer penalties. So people in New York today can transfer all of their assets today and qualify for full Medicaid home care benefits tomorrow. There is no spend down for home health care benefits, and there are no private dollars coming into home health care as a result. Assemblyman Gottfried mentioned those dozen cuts that have been proposed over the last 18 or 19 years. One of them is to apply these penalties to home health care. And we're anticipating that may be one of the ones that ends up coming back. And we'll be lobbying against that in Albany again. But the idea of private financing and having people, number one, manage their own care, and number two, pay for their own care initially, will rationalize the system, because I sit with seniors every day, and the last thing they want to do is give away all their money to get health care services. They will pay for it. They'll pay for it wisely. They'll pay for it in a way that suits their particular needs in the setting that they want to receive the services. That's kind of the core issue that we see, and the labor force is one of the drivers for that.
Any other questions?
You can tell I care about this, right? I think all this dialogue is
Wait until you
Okay. I think all this dialogue is wonderful, and I think there's a lot of great ideas. But the word I haven't heard is housing. I'm just kind of curious to hear, and I'm not directing this question at any of the experts in particular, but you know, there's a housing crisis in this country, and that is, as most of us know, the #1 asset for the majority of Americans, and it does come into play big time, not in, obviously, impoverishing yourself, which I think is a huge problem with the Medicaid program, but could someone speak to, use the H word here, not healthcare, but housing, and how that plays into it?
Well, I'll make a quick comment on it. I mean, I think the housing of today are the homes for the aging in the future. People, particularly your baby boomers, are a different cut of individual than what you've seen in the past. And I think that you're not going to develop and build housing, assisted living facilities, and a whole panoply. And it's my own opinion. I'm not speaking for the group. You're not going to build a whole panoply of places that'll either be Martha Stewart focused or, you know, whatever. There'll be some of those, and those will be for higher-end individuals. But most of the people who work and live in New York City are not high-end individuals. They're people with low income. They're not going to move to Arizona. They're not going to move to other parts of the United States. They're going to age in place here, and they're going to need the support services to coordinate the care. So I think that the key is, how do you take the financing, which is in effect the binding, like an egg, it binds things together, and bring that more together to be able to take the whole array of services that currently exist and that will exist in the future by organizations and providers and other entities that will develop them in New York City, to put that all together so that they can age in place in a quality setting with quality outcomes and a satisfaction level that will support what they need, where they want it, and where they want to get it.
One last question.
Mental health. Something that we haven't talked about today. A significant number of people who are in the long-term care system have mental disorders, but their needs aren't being met. It's a critical component to restructuring and refinancing and reforming long-term care. How can we elevate its importance? How can we include mental health as part of the conversation? How can we increase access to and integration of mental health services in long-term care?
Does somebody wish to handle that?
Carla?
So, this continues. Is this on? I think in terms of the mentally ill population, one, they already are being served significantly in our existing systems. You know, I don't have to speak for the people, many of the people in this room who actually are providers of services, but I would guess that every one of them would say they could describe the number of individuals that they serve every day that have mental illness and disabilities. I do think that it's not only an issue for the mentally ill. I think we have an aging population of individuals that are currently served in our OMRDD system, and so it is a huge problem, and it will grow. I think that the service provision needs to also be addressed by our colleagues at the Office of Mental Health. I think one of the real serious issues is there aren't community-based mental health services widely available. Like as Eli has said, people want to stay in their homes irrespective of the nature of their disability, whether it's a physical disability, age, you know, whether you've aged or you have some other disability. You want to be in the community, and so I do think we need to recognize that we need to expand, just like as we need to expand the workforce as it relates to direct caregivers. We talk about CNAs and home health aides. I think we need to also invest in a workforce for mental health professionals as well. I mean, but I really encourage a dialogue with the Office of Mental Health as well, because I think the service provision is one of the biggest issues that I see from, you know, a long-term care perspective. And maybe some of the providers that serve this population would also want to answer this question. Thanks.
If I could, just briefly, what we see is misdiagnosis at the physician level and mistreatment at the transition level when people are going either one from home, from hospital to home, or hospital to nursing home. There has to be better education in terms of the medical providers. In the compact, I'll refer back to that, it is a plan of care established by the individual's own healthcare provider. And the diagnosis and treatment should be really at that level. But what we also find is that people in the long-term care profession are not trained to spot and diagnose mental illness as one of the corollary problems. And when you work with, in our office we work with them frequently, a qualified geriatric care manager who has had that training and can discern between dementia and mental illness, then you can at least spot the problem and begin the treatment. But without that base level diagnosis, whether it's at the physician level or in the care management piece, you don't get any of the services that you need on the other side. And I think that the geriatric care management profession needs to be part of this entire dialogue, because case management cannot be done on a purely medical model. Geriatric care managers are cross-trained to spot social issues, healthcare issues, the financial issues, and you really need that new breed of worker, a geriatric care manager, in this system to make it work.
Okay, I'm going to take the privilege of being up here to basically close discussion. Before I make a couple of comments to capture what was discussed here today, I want to thank Dr. Kerrey and the New School for hosting this today. I also want to thank all of our co-sponsors. I want to thank AARP. I want to thank the Continuing Care Leadership Coalition, the New York Association of Homes and Services for the Aging, and certainly the American Association of Homes and Services for the Aging, who are always in the forefront on these issues. And so we've heard a lot of ideas this morning, and I've jotted some stuff down just to sort of recapture. Some of the ideas have been proactive, such as ASA's National Long-Term Care Insurance Trust, or the Compact, and other options for greater private participation in future costs of retiree health care. And some are defensive, focused on the growing costs to public programs of long-term care and how to move these chess pieces around given the financial situation that we have in our environment and will experience, in the hopes of reducing the inevitable increases that are going to occur. And frankly, I don't think the ideas are not the issue. Implementation is the issue, as I see it. The time is now, really, to develop consensus on expeditious development and implementation of a public-private partnership that will enable today's baby boomers to retire with some measure of confidence that they can meet their health care needs over a 20, 40, and even 50-year retirement. Furthermore, Wall Street is still right in one regard. Past performance is no indicator of future performance. If we continue to think and act in Medicaid and Medicare silos and try to micromanage cost shifting among existing programs, we'll fail in our obligation to our seniors and our disabled population, and fail to truly achieve client-centered care. Therefore, I would challenge all of us to analyze lessons learned from our past and build on our current strengths, but focus on anticipating the needs of future seniors. So here are some of the core principles I think I heard today that were enunciated by a variety of different people. One, long-term care coverage should be a right, not a privilege. Two, the health care setting of tomorrow is the home. That's where the center of focus is going to be. Three, the availability of staff to deliver long-term care services will grow and not get less, and will be a major challenge. Future retirements will be longer. Some may be even longer than the work years that preceded them. Therefore, the total number of people who may need long-term care will grow significantly over time. People will live longer with chronic disease and chronic conditions and more diseases such as AIDS, and they will become chronic. Future retirees must begin contributing to the cost of future care from today's paychecks. We must rely more on technology for primary, preventative, and chronic care because there simply won't be the workforce to support all those services, and future retirees will be accustomed to iPhones and laptops and universal internet and wireless access, etc., and they're going to demand it. Future retirees will be demanding, period. And we better listen to them because they are us. So I want to thank you for all the provocative discussion. And now let's go out and get to work on social consensus building and implementation. Thank you.